Hello, I'm Richard Smith from Patients Know Best. Paul, you glossed over comorbidity, but most of healthcare now is about people with multiple problems. So isn't that going to undermine what you're doing?
Well, we do take into account comorbidity, and there are a number of ways of doing it, and there are a number of coding systems to allow you to do that. The predictive models that we presented in the BMJ paper take into account comorbidities. I mean, there is a facility to record something like 20 or 30 different diagnoses in each record of care. So we are able to take that into account. There is some variability in coding, and we've done a lot of work doing sensitivity analyses to see, at what level of coding that really makes a difference. And it does make a difference, but actually it's the best data we've got, and our models are pretty good at predicting outcomes.
Paul, thank you very much. Any thoughts or a perspective on applying the same principles to other health settings? In other words, not traditional secondary care, four walls, but primary care, mental health or community services. And if so, what do you think the response from the relevant interests might be if you applied some of these same approaches?
Oh, yes. What a great question. We would love to apply some of these routines to primary care data. And I know in some respects primary care is way further ahead in terms of collecting data. But in terms of accessing data, who gets access to primary care data? It's actually extremely difficult. And with the fallout from care.data and now GPs, I believe, have the right to exclude their patients from the system, and they have to opt into the system rather than opt out. Is that not right?
An individual has a right to exclude themselves, their data, from being extracted from GP practice when a GP that we know of attempted to provide their patients locally just what we described, he was threatening his job.
Right, okay. Well, there has been a recent ruling through CAG that says that it is for the GP to decide whether they include their data or not, which essentially, as an opt-in process, means that care.data is likely to be dead in the water in terms of a comprehensive 100% collection of GP data. I have a representative from HISIC at the back there who.
Sorry, I'm Phil Booth. I coordinate Med Confidential. We have been one of the vocal critics of care.data, and we sit now on the advisory group to care.data. So we're aware of what it does and doesn't do. So, if we're talking in a room, let's be accurate about what is actually the situation.
Whatever the situation is, we do not have access to primary care data. We have applied for access to primary care data, and very few people do have access to primary care data. And there is not a resource, a central resource, which links 100% of primary care consultations to hospital episode statistics data, which I think is the real power of primary care data and the richness of data that we collect. It's linking of these data so to be able to track patient journeys. So whatever you say, no one has access to these data, or very few people has access to these data.
Just a point to actually explore what Charles said. So Charles, you mentioned a people's health data movement. I think one of the issues and what we're talking about, and it is certainly the case, that primary care data resides on systems that are not generally available to places where it could have great benefit. But the way to go about it is more along the lines, I think, of what you're talking about, which is something which engages with, if you like, the patient end, the people whose data it is, rather than what has happened up to now, which is those people who would want to lobby for access or otherwise have benefit from the data, driving a process that excludes patients.
And mental health, if we want to talk about mental health, there again are limited data, particularly about mental health outcomes. And I think what we need to see is development of outcomes, development of data collection, so that we can look at variation in outcomes and delivery of care in mental health services. But at the moment, we're not there yet.
I think this is really important, and clearly, it's the core of what people think. So the system that I sort of illustrated in that rather busy slide with lots and lots of data fields on it, the permissions that a patient has accorded to data sharing is recorded in the primary care system. And that either allows data to be visible in that field or not. And my experience at the secondary care end, in my own clinic, is that most people have no idea what they consented to, gave permission for, and so on. And when they actually see the power of the data exchange and the visualization, they then, of course, say, I will go back to my GP and change the way I have had given permission to the system. So that's where I think the kind of people's health data movement starts, at the one-to-one interface, but we also need large-scale population interventions of the sort I illustrated around teaching of children, teaching of adults, and so on, in formats which are not about health.